newsletter, the one that came out this past Monday. Yes, just a little bit of comment by way of introduction to our speaker. Mike came out of Indiana and out of Indiana University, where he studied political science and decided to become a journalist. The first 15 years of considerable achievement spent at the Louisville Courier, and from the get-go he was focusing on medicine, on public health, and the writing that he did. He was reporter there, editor, Washington correspondent. He came to the AJC, as many of you will well remember, in '87. By '91, he was working with Hal Strauss on a major series on disparities in outcomes, medical treatment for poor folks throughout the South, a really major series on that. By '92, he was editor of Science and Medicine at the AJC, eventually became Metro editor, last 4 years on the editorial board, and what I remember, and I think a lot of you will remember, is a series, many editorials about Grady, and of course we'll be talking about Grady today. The book that came out last year is here at the front, The Spirit of Charity, and he's quite willing to send some of the books home with you if you would so desire. They're up here at the front, and he'll handle that. He is, of course, going to talk about the book, the subject of the book, the charity, so-called charity hospitals. But he's quite willing to talk about all manner of related subjects, including journalism itself, the probable subject of his next book. We were nudging each other about what's happened over the weekend. I expect most of you were following as well, where Trump and his spokespeople not only stopped denying the lies, but started defending the lies as what Kellyanne Conway called, quote, alternative facts. It just strikes me as so appropriate that we are starting this calendar year with two journalists, Hank Klavinoff, whom we had last time, and Mike today. So he'll let you know what he'd like to do as he proceeds here. I know for sure that he wants a lot of dialogue, not just monologue from him, but dialogue with you, and so we'll look forward to that. Okay, let me turn it over to Mike King.
Thank you. How are we doing on voice? Can everybody hear me? Yeah. We good? I'm going to put this down here. Oh, sure. Come on.
I don't think it's on.
It's on. It's got the green. Can we hear? Are you hearing, Greg?
I don't think that's as loud as it could be. No.
How about now?
Hey!
And Jesus came in. Thanks to the Emory Emeritus folks for having me. I appreciate the opportunity to be here. It's always good to be at Emory. Gretchen told you that I'm a little distracted. My wife had hip replacement surgery this morning at 7 o'clock, so, but she's out probably kicking footballs right now. Dr. Roberson, of the wonderful surgeon that he is, assured me that I could leave, and she was actually in her room before I left, doing fine. So I'm feeling confident. But my phone might go off. Just would be somebody keeping me up to date there. I do want to talk a little bit about the book. I want to talk a little bit about healthcare in general. Answer as many questions as you have. Would love to speak a little bit about the role of journalism today, how that has changed so much in 6 years since I left the newspaper business. It's dramatic how fast the decline of traditional media has taken place, and what has replaced it as an alternative. And speaking of alternative, I had a good joke the other day, particularly after Kellyanne Conway talked about alternative facts. yesterday. And I was thinking in my mind, remember that wonderful, not wonderful, terrifying scene of Richard Nixon saying to the assembled press corps that the American public needs to know the president's not a crook, and I'm not a crook. Today we would have said, American public needs to know that their president's not a crook, I'm not a crook, I'm a purveyor of alternative ethical standards. I just have a few brief prepared remarks, and I want to go through some slides that just might jog your memories and jog my memories of things I want to talk about in our dialogue, but I really would like to spend most of my time answering your questions and hearing your comments. In its 125-year existence, Atlanta's Grady Memorial Hospital has weathered every stormy passage through our nation's fitful journey toward equal access to health care for all its citizens. This next wave, however, could be its hardest. As Georgia's largest public hospital, its very mission is to provide care to anyone who needs it, regardless of ability to pay. That and the education it provides for doctors in training makes it essential in Atlanta and Georgia's medical marketplace. For many years before the advent of health insurance, it treated its poorest patients with no questions asked. But in the 1930s, 40s, and 50s, as people started getting insurance on the job, some of Grady's patients switched to other Atlanta not-for-profit hospitals to get their care. The biggest change came, as you know, in 1965 when Medicare was enacted and those other hospitals started getting many of the elderly patients Grady had been treating for free. Grady hoped it would keep them, but it was becoming increasingly difficult to compete in a newly energized hospital market where attracting Medicare and privately insured patients was the key to survival. Instead, both these waves of changes, nobly designed to open access and make healthcare more affordable, left Grady treating mostly the uninsured and poor, a small fraction of whom were covered by Medicaid. It's still like that, which is why less than a decade ago the hospital teetered with insolvency. A change in governance has stabilized it, and the implementation of the Affordable Care Act with its promise of getting more Americans insurance has also helped, but not as much as had been hoped. Still, those tumultuous changes in the marketplace may be nothing compared to what is about to happen now. Grady and large public safety net hospitals like it around the country, you know these hospitals, you've heard of them, they have iconic places. County in Chicago, Parkland in Dallas, Jackson Memorial in Miami, Bellevue in New York City. These places are about to be buffeted again, this time with the gale force of new approaches to health insurance reform aiming to dismantle many government rules guaranteeing access and basic benefits. The new ideas are designed to increase the responsibility of Americans to plan for and pay for much of their own care. The details of how the nation might replace its most recent wave of reforms, those requiring everyone to have insurance and expanding government coverage and benefits for Americans who can't afford it, have yet to be worked out, and those changes will not happen overnight. But elections matter, and the country has clearly changed directions once again in our decades-old healthcare journey. To hear conservatives, the plans they will enact will have the potential to be so successful that we may not even need public hospitals. Many of them talk like they found the holy health care grail. Yet when pressed for details on how such a plan would work, the president hasn't been able to articulate any real plan. Pressed by opponents during the primary election campaign, Mr. Trump assured Americans that while he couldn't provide specifics what Trump care might look like, he, quote, will not allow people to die on the sidewalks and streets. Actually, such a crude determinant of health care access is precisely why we have public hospitals. You might say rule number one of American health care policy over the years is that we don't let poor people die in the streets. We take them to public hospitals and hope their skilled staff, doctors, nurses, and medical technicians will rescue them. And when they do, we send them back out to the streets too often to defend a $3.2 trillion medical industrial complex, a system that costs vastly more than any other in the world, yet measured by the health of the population produces the least bang for the buck. Now, to be fair to our new president, Trump is not actually a details guy. So you wouldn't expect him to have a specific plan, but House Speaker Paul Ryan is supposed to be the real policy wonk, and as Trump's nominee for Secretary of Health and Human Services, Tom Price, a lifelong opponent of government regulated health in his days as an orthopedic surgeon here in Atlanta to his role as the anti-Obamacare voice of the GOP in Congress. These guys have some big plans. All of the Republican proposals would essentially reverse much of the regulatory structure in place now under the ACA. They would change the health insurance marketplace in a way that would financially benefit younger, healthier people so that they could buy bare bones coverage and pay much cheaper premiums with tax credits. Republicans propose to give them these tax credits as opposed to the subsidies that the ACA now has. At the same time, they would likely impose higher premium and out-of-pocket costs for older, chronically ill Americans who have not yet qualified for Medicare. The uninsured elderly would also get a tax credit, but it is unlikely under any of the plans to be enough to buy the basic benefits they have now. And that's the trade-off. Republicans promise these plans don't necessarily return us to the bad old days before 2010 when the U.S. was approaching 50 million people without insurance, and insurance carriers could reject applicants with pre-existing conditions. But they also don't come close to covering as many people as the ACA has succeeded in getting signed up for insurance since it was implemented 3 years ago. And keep in mind, even with its success, the ACA has left between 25 and 30 million people without insurance. Rule number 2 of American healthcare policy is that the more uninsured people there are, the more the country depends on public hospitals to ensure we don't violate rule number 1, the one about not letting people die in the streets. A huge portion of those left behind this time will likely come from among the 12 million new patients covered by Medicaid, thanks to the ACA. For Grady and other public hospitals, that's bad news, because Medicaid happens to be its single most important source of revenue for patient care. All of the Republican plans want to fundamentally alter Medicaid, moving away from a defined set of benefits set by the federal government. Instead, Washington would send a lump sum to each of the states to come up with their own plans. This is why the concept is more than a little worrisome to public hospitals. The states already get to decide who Medicaid covers, and many of them, like Georgia, are notoriously stingy. Georgia is one of 19 states that have refused billions of dollars in federal funding to expand Medicaid as envisioned and fully paid for in the first 3 years by the ACA. Georgia has been, for 3 solid years, turning down $9 million a day to send back to the federal government because it didn't want to expand Medicaid. It already has Medicaid payment limits for doctors and hospitals that are well below their actual costs and not even close to what they're taking care of, what they're getting for taking care of Medicare patients. Under the GOP proposals, the states could now also decide what services would be covered, whether Medicaid patients will have to pay deductibles and out-of-pocket charges when they need care or other fees. If reimbursement rates continue to be so stingy, public hospitals would not just eat the loss of their actual costs, but they would also now have to absorb the unpaid bills of Medicaid patients who can't afford their deductibles or out-of-pocket expenses when they do need hospital care. Whatever happens, the result of this upcoming effort at healthcare reform will no doubt stir the waters once again for America's public hospitals, whose mission, we should keep reminding ourselves, is to not let people die in the streets. The big question is whether these same hospitals will sink beneath the latest wave of change. If they do, we should ask ourselves, who will rescue them? That's my political spiel for the day. It won't be the last. I want to go through some slides, just to sort of jog your memory and let you know. We're at 125 years this year of this hospital, 1892. This is the original hospital, the building's still down there. It's human resources now, isn't it? Yeah. Right, everybody gets their IDs, their employee IDs with it. But this is the original hospital, actually right before it opened in 1892. The result of interestingly, of a business, political, community partnership in 1892, not unlike what exists today. Half of the money was raised by it was about I'm trying to remember the dollar figure. I'm sorry, I can't remember, but half of the money was raised by the business community donations. The other half came from tax money of the city of Atlanta. This is after actually the children's ward had been added. This is the first ambulance in 1896. This man, I'm told, was Grady's very first patient in 1892. His name is Alan Kimball. He was hurt in a railroad accident. He eventually went to work for Grady and was an orderly on the floor, and eventually drove, if that's the right word, for the ambulance. We talked a lot about the history of public hospitals in the United States. Charity Hospital in New Orleans, of course, and Bellevue in New York City are the two oldest public hospitals in the country. These are hospitals that began in 1736. So this is colonial era stuff. This is the Charity Hospital of 1832. That's it's the third charity hospital. The original hospital was built by a French nobleman who convinced the Sisters of Charity to help him set up a hospital and take care of sick seamen. In fact, a lot of public hospitals in the United States are the result of an act, a law created by President John Adams to set up what was then called marine hospitals. They were the first public hospitals in the country. One of them was in Savannah, Georgia, and that was the first public hospital in Georgia. This is the charity that was abandoned after Katrina in 2005. Actually, this is after the storm. It's empty at this point. I love this picture just because it was taken about 3 days before the storm. Huge public hospital. At one point, I think 2,100 patients. Built in the New Deal era, and in those days, hospitals were architectural wonders too, in lots of ways. And this was an interesting, troubled, wonderful place. Closed in 2005 after the storm, when the state of Louisiana decided, it could open. It was all set to reopen. It was within 3 weeks of reopening after the storm. The state of Louisiana said they'd had enough of charity and were interested in replacing it with a hospital through the university system, and decided that this one would go. It's still, by the way, sitting there like that. Yes.
Is that the one that lost electricity to every floor?
Yes. The basement was flooded, the emergency room was flooded, and everything eventually lost. Now, this was, of all the New Orleans hospitals, big New Orleans hospitals, this one actually lost the fewest patients during the storm. Memorial Hospital in New Orleans was the scene of that terrible situation where doctors were literally having to triage people, letting them die because they couldn't get them out. Charity did not have that same problem.
Regarding that architecture,
yes,
is that motivated similarly as to Grady as to separation of races at the time?
It wasn't. Not exactly like Grady. They were intermingled. In 1936, when this hospital was built, I think it was probably 80% black patients at the time. So that wasn't as big an issue as it was here in Atlanta. But it was a works progress hospital. A lot of federal dollars spent to build it. This is the other big iconic hospital. This is Cook County Hospital in Chicago. This building was 1915, I think. It is still sitting there vacant too. There's a barbed wire fence around it. Just a block away is the new county hospital. This is the scene of the nation's very first blood bank. This hospital has to trace its roots to I think it was 1832 or something like that, and its relationship with the Rush School of Medicine. But that's also, I think this was 1,900 beds. show you this one because it's a Grady nursing school photo. Grady had a nursing school for many years. It had a white nursing school and a black nursing school, just like everything else at Grady. It stayed in, not only did Grady provide most of the doctors for the state, it also provided a good hunk of the nurses for the state back in the day. I love that. It's just one of my favorite photos. Sorry, I can't make it bigger. This is the replacement hospital that was built. I'm losing my dates here, but I think in about the 1830s. This building no longer exists. And it was,
I don't know, it could be
1930.
I'm sorry, 1930s. This building was referred to as White Grady. It was the first time we actually had patients in separate buildings. So this was called the White Grady for years. This is a ward picture from actually the original hospital, not from the one you just saw. I love these old photos. These are all available, by the way, at the Atlanta History Center, where I spent way too many hours. I love this one because this is the waiting room for the black hospital. Emergency room, right. Kind of crowded, not unlike today. Very tiny picture, but this is the white side and the white hospital. Same thing, emergency room. And emergency rooms in those days were literally the entrance to the hospital. Everybody came through the emergency room. This is a WPA project that began during the Roosevelt administration, where there was some construction going on. I've used the Roosevelt administration history mostly because I think it's indicative of sort of how Georgia has approached the relationship with the federal government and how it uses federal dollars. During these years, Georgia was very happy to receive dollars from the Roosevelt administration for bricks and mortar things, roads, building construction, and other things. But they weren't as interested in getting it if it was directly connected to wages. And in the New Deal era, there was some money sent to Georgia for the hiring of nurses at Grady. And it was going to come with some strings attached. The strings were that Grady had to pay the prevailing wage of nurses across the United States. Well, that was inflated some because a lot of the nurses were working in the Northeast where there were unions and other things. So the prevailing wage for the nurses hired under this New Deal program were going to be higher than the wages for the nurses that were already there. And because of that, the state of Georgia said, keep it, we don't want it. So they've lost an opportunity to get 300 nurses because they didn't want to pay the federal minimum for nurses in those days. And I raise that only because it helps you understand that 70 or so years later, we have a history of saying no to federal dollars when it's things we're not interested in. The other thing that happened during the Roosevelt years was the murals, the artwork that took place. And this is actually in the Children's Hospital. I'm sorry, I can't remember the name of the artist, but and that's all gone, of course. White Grady. This is a clinic. The building's still there, right? Steiner Clinic? Yeah, Steiner there. Originally, a cancer clinic, one of the first in the country, was at Grady Memorial Hospital. Parkland Memorial Hospital, Dallas, Texas, 1957, just before it opened. We know Parkland mostly from this scene, November 22nd, 1963. Parkland's a huge public hospital in Dallas. It reminds me a lot of Grady. Of all the hospitals I visited, I think Parkland was most like Grady. No two public hospitals are exactly the same. Hang on, just gotta, okay, we're good. No two public hospitals are exactly the same, but Parkland is about as close to Grady as any of them because it's surrounded in a marketplace by other hospitals. And interestingly, the CEO of Grady came from Parkland. This is the Grady that you know and love today.
The Grady's.
Yeah. This is the oldest part of the building, 1958. These are the additions in the 90s. I show this slide because this is the Grady's. One half of it was black, one wing was white, one wing was black. It was a Noah's Ark of hospitals. It had two of just about everything. Radiology departments and other things in its first few years of existence. Medicare, 1964 and 65. Civil Rights Act and Medicare changed all that. Once Medicare was enacted and public hospitals had segregated facilities, they could not receive federal dollars. Literally, over a period of about 18 months, every public hospital in the United States effectively desegregated.
Excuse me, what's
Yeah.
in the shorter buildings in front and what decorative?
This here, these are clinics, clinical buildings where the patients go for outpatient. Yeah. All right, here's the other end of that.
That was in the 90s.
92, 93, 94, somewhere. John, does that sound right? Mr. Henry? You don't remember?
Early 90s.
Here, the problem with this, the other reason this is a good slide is when this was adopted, or this was built, it was the largest building project in the States, most expensive building project in the States history. It's $307 million to do this in the 90s. And the cost overruns were terrible. In fact, there was one whole wing that left, they had the two floors had to be left undone because they ran out of money, which did not sit well with politicians, and correctly so. And it sort of tainted the relationship Grady has with the lawmakers and the local folks because of how that was so botched. It's now completely used. In fact, Dr. Gabriel has some clinic space in one of those open floors there for a while. The reason I like this is the Fulton County Health Department, right here. Grady Memorial Hospital. Two different universes, two different worlds. Not quite sure why. A lot of other major cities around the country, Denver, Dallas, others, have what they call health and hospital systems in their counties where they connect and coordinate the money that's spent between the hospitals, public health agencies, and the clinics. This sits here by itself with its own budget. This sits there with us.
And you can see the Glen building.
And the Glen building is right there. This is the Glen building.
Just a comment about the Department of Health building, by the way. They are leaving, and Grady bought that property, and a new building, an outpatient ambulatory surgical unit with surgical clinics going to use this plan. So
Are they tearing it down or?
That in a couple of years.
They
Could you repeat that, Mike?
Yes, this is, by the way, this is Dr. Cheryl Gabriel Mendoza from Grady Hospital. She's runs the cancer surgery center there, and my wife's cancer surgeon. She's in the book.
But it's coming down. That building is completely coming down. The health department's moving out. We are trying to establish better relationships with the health department.
Right. It's in
certain pockets we have, like for cancer referrals, but in other pockets we have to, as Mike mentioned, it's just, we
slug through it.
do that.
Mike, don't you think one of the reasons it was separate, the health department was Fulton County only?
Right.
Whereas Fulton DeKalb Hospital Authority, and so there was a conflict. They did not want to have DeKalb involved in this particular thing.
And not to mention, it would have very complicated the tax structure to combine the two. In Texas, what happens is they have regional health departments in multi-counties. That's an approach Georgia could take, but has chosen not to do that. It does for health departments, but it doesn't necessarily for hospital systems. And by the way, I'm neglected to tell you, but you probably figured it out. 1892, it's the city of Atlanta that funds Grady. By 40 something, it becomes a Fulton and DeKalb County function. The City of Atlanta is no longer connected to it. It's now a function of county government. Okay. Go back here. One of the most interesting stories about Grady's new construction in 1958 was that they had taken into account all the separation, all the Jim Crow aspects of healthcare. And so there was the white wing and the black wing. What they had forgotten was that there was only a single laundry chute at the time that was right down the middle of the corridor, the connecting corridor where the elevators are. Not to be stymied, they decided that black patients would have their soiled linens go down on Monday, Wednesday, and Friday, and white patients would have theirs go down on Tuesdays, Thursdays, Saturdays, and Sundays. Now, the reason I say that is because, interestingly, when they got down there, it was all black ladies who took care of them. But nonetheless, they upheld their segregation. So that's the Grady we know and have come to love. I just want to end on a couple of slides here. When I was doing the research on this was stunning. This is the ordinance that was passed by the City Council of Atlanta in October of 1891, just before the hospital opened. And you may not be able to read it, but it says the City of Atlanta pledges itself to contribute to the fund for the purchase of the grounds and erection of the buildings at Grady Hospital, that when said buildings are completed and ready for use, the City of Atlanta will accept and maintain said hospital. Now that's kind of the loose language that we have to work with over whether the government has some responsibility for helping Grady. But that's the extent of it, actually. But what was interesting about that was a month earlier, when the council first considered this ordinance, there was still a lot of debate about Grady, about whether it was a good idea or not. You'll see the handwritten version of this, which is essentially the same thing, it's just handwritten. But it says, we'll accept and maintain said hospital, and then scratched out here it says, as a public charity. Which makes me think that we still are in that position. We're not exactly sure whether we want to do this, whether we really want to function, whether we really have a public duty to provide a charity, a charitable mission here. And I think that's still a problem in our country. We still have not quite gotten there. We keep coming up to the line and then backing off a little bit because we're not exactly sure we want to do that. And the reason I wrote this book was I think that's the big issue that we have to confront as a society, as a nation. And public hospitals make it easier for us to not have to confront that. And it's time we do. I want to close with the quote that I used for the book that is from Franklin Delano Roosevelt's 1936 Rendezvous with Destiny speech. I'm sure a lot of you all know about that, but this is one of my favorite quotes. He says, better the occasional faults of a government that lives in a spirit of charity than the consistent omissions of a government frozen in the ice of its own indifference. And that's where we are, especially now. Thank you. Yes?
I recall, and maybe it wasn't this time, but I recall a public debate on the Republican side where one of the candidates said, if you can't afford for hospital care, maybe you shouldn't get any. And the audience just went wild. And so, is that where we're going? I mean, if maybe what we need is if you're black, you get public charity, but if you're white and middle class, then you get the dialysis.
I think there's a legitimate ongoing discussion about the effectiveness of some of our social programs and health services programs, how well they are carried out, and whether they're meeting their purposes. What I have seen it degenerate to in the last few years is this feeling that somehow these folks are unworthy of our government beneficence, of our charity. And you see it, you still hear it from time to time. It comes up from time to time, and it manifests itself, I think, with things like, I think Tom Price mentioned this in his hearing last week, that Medicaid is, he'd like to see Medicaid turned back over to the states so that the states could set their own rules, including, he said, maybe requiring people who are on Medicaid to be seeking work. So it's, and this is what concerns me about, thank you, this is what concerns me about Medicaid. And I think we may have gotten off on the wrong foot on it in 1965. The trajectory of Medicaid got badly warped when it was seen by Congress in 1965 as a welfare program, not a health care program. It was an extension of what was used to be called the Care Mills Welfare Act that allowed local governments and county governments in particular to be able to set the stage for how much public money would go to people who were poor. So what we've seen in, what I think we'll see in the next few months, if not years, is a debate that's kind of similar to what we went through in the 90s with welfare reform. That, okay, well, we're going to give some money, the federal government's going to spend some money, less if we can than we're spending now. That's a major goal of all these plans, is to spend less money, not whether they spend it effectively, although they would say so, but less money. And we will let the states decide the worthiness of the people who qualify for it. Now, in my state, I'm a little worried about that. I'm not as worried about it in Michigan and Ohio and a few other places where there's a richer history of the states working more cooperatively with providers and qualifying people. Chicago, for instance, in Illinois, Cook County Hospital set up a Medicaid program in 2014. A year early, they enacted Medicaid expansion a year early. The feds gave them permission to do so, and set up a program with its community health centers and federally funded community health centers and its other hospitals, cooperating hospitals, to take care of 100,000 Medicaid patients, very specifically with the goal of making sure that they stay healthy and stay out of the hospital. That's a good goal. That's a good thing to do. Now in our state, Grady Memorial goes to, with a bunch of other safety net providers, goes to the state government in 2015 and says, can we do something similar like that in Georgia? With at that time, I think they were talking about 50,000 people below the poverty level who they would take care of with the help of the federally funded community health centers. And places like Mercy Care, which is a wonderful nonprofit community health center, to help take care of people with diabetes and other chronic conditions so that they don't keep going to the hospital to get their care. And they went to the state with it, and the state said, do we have to put up any money on this? And Grady said, well, no, we'll use the contributions we get from Fulton and DeKalb to fund this. That'll be our contribution, and the feds will put the rest up. And the state said, nah, don't want to. Because it might cost us. It might cost us in the long run. So, I'm sorry, but anyway, that's where I'm a little worried about this, about what we might see with how we change Medicaid in the next few years.
Mike, I'm Bill Casarella. I was working in Grady for 25 years as the executive associate dean, sort of the ambassador from Emory to Grady. And the thing that strikes me, the reason why Grady has survived is really the result of 4 little words from the Woodruff Foundation, from Jimmy Williams, who asked me through the dean to write a report about what Grady's situation was in 2008 regarding its finances. And I wrote this report listing all the things that it needed And the bottom line was that the hospital needed an immediate infusion of $250 million, plus $68 million that it owed the university that was fronting it.
Yeah, and
Not the 250, but in addition to that.
Right.
And Jimmy Williams said, we can do that. Talking about the Woodward Foundation.
Right.
And they did.
They did.
And
But tell them why they did it, why they changed their mind, or why they thought that was a good idea.
One of the things that they insisted on was a new mode of government of
Right.
the hospital, a new board, that they wanted the entire board removed, and they wanted a new board that was based on community leaders, which they did.
Right.
And the combination of those things is the reason why Grady is still there.
Right.
And they also encourage many of other community leaders, like Bernie Marcus and UPS and all kinds of other people, to contribute. And that's why Grady has pioneering stroke center,
right,
which has saved thousands of lives.
Right.
And I can't say enough about Jimmy, about the Woodward Foundation, and about their willing to do what it took 9 years ago to save the hospital.
Right. And it was the work of Pete Carell and a bunch of other folks who really put it out there so that the philanthropic community of this city would feel comfortable saying, okay, we'll put some money into Grady because we don't think it's going to get wasted.
Well, that's right. And, $318 million is a significant amount of money.
Yeah.
I don't know whether or not there's a will or I have to do that again, but the new administration, we'd had in 12 years, 11 different CEOs. And it was very difficult
Yeah.
to run the hospital level.
Including one
One of
sitting
them
to the
sitting
left
right
of
next
you.
to you.
Now, I know all about
Yes, who
that.
gave me a Christmas present in December of
Well, yeah, but
2005.
John was very short.
Rise and speak louder.
Yes.
This is John Henry, by the way. Those of you who don't know him, he ran the place for 4 years, 5 years?
4 years. I spent 40 years at Emory in 1 month, and then Andy asked me to go to Grady. That was in September of 2003, and I stayed there 4 years. But Bill is absolutely right. When the Grady Memorial Hospital Corporation was founded in January of 2008, that became the difference. Pete Carell was the first chairman. Today, we've got wonderful chairman and Frank Blake, retired from Home Depot. And if you go through the list of all the people that are on that corporation board, you'd be amazed at what they are. Some of those are the president of Georgia State, the dean of Emory School of Medicine, the president of Morehouse College, Morehouse School of Medicine. You have the general manager, Marriott Marquis. You've got a retired person from Coca-Cola Foundation, Lisa Borders is on it, and you go on and on. These are community leaders. Pete Carell had some good people too, like Tom Bell, who was from Cousins, and quite frankly, my role there was kind of hold things together, and I knew that I could not get the philanthropy needed because of the hospital authority. The hospital authority is still there, but they've turned the operation over to this corporation. And I think John Hoffman, as CEO, is a wonderful guy. And if you look at all the people that he has brought in on his staff, they're all first-class people. And all you have to do is go to the Grady webpage and you look at the board and you can look at the management. And quite frankly, why people have given money from the foundations around the city has been because they have faith and trust in the management, and they have faith and trust in the board. And without that change, I don't think any of this would have come about.
Actually, without it, I think it would have crashed.
The other thing that I think many people in this room know, Bill Casarella knows better than anybody else, but without Emory University School of Medicine residents, and without the residents of Morehouse, it would be very hard for Grady to operate. And one of the reasons that I agreed to go to Grady was the fact that my son had gone through an orthopedic residency under Tom Whiteside's at Grady. And I felt that I should give something back to the community because I went at a salary significantly less than what I was making at Emory. But here again, you cannot say enough about some of the staff that are there, like Cheryl there. I mean, she is a wonderful leader, and Emory has got some of the best faculty on the face of the earth that are based at Grady. So I think Grady has a wonderful future. Yes, there are challenges ahead, but we all face challenges. We face challenges at Crawford Long and at Emory. Dan Barker can tell you more about those than probably anybody here. But at the same time, I think that Grady has a bright future if we continue to support it with a board that is based like it is today.
I think you're right. My cautionary note here is that the counties have to fulfill their commitment, and they're not, in my view. If you look at Grady's budget in the 90s, before you arrived, the two counties were contributing something like $110 million a year towards Grady for its operations. They were doing that when Grady was working on an operating budget of about $450 million. For the last 11 years, the county's contribution the two contribution has hovered at about 60 million. While Grady's operating budget is pushing 850 million. So as a percentage of its overall budget, the counties continue to dwindle their support. And the reason why that's important is I think it's difficult, if not impossible, for public hospitals to survive on patient revenue alone. And at Grady's patient pay mix, for those of you who are not familiar with how hospitals operate, if you're looking at a patient pay mix of 55% either uninsured or on Medicaid, that's a pretty toxic business model. And when the state sends $9 million a day back to Washington, that would at least get some of that Medicaid, some of those patients on Medicaid and some of those costs reimbursed, then that's harmful. And if we, and here's a real big concern I have about this, is when we got through that 2008 terror of almost losing that hospital, and the business community stepped up to bat, and the foundation stepped up to bat. I worry that in my mind, the public officials at both the state and the county level said, "Oh, well, that's over. We're over that now. We don't have to worry about that." In fact, those key essential services that Grady and only Grady provides are expensive, and they need government funding. Whether it's trauma care, everybody knows trauma care is great at Grady. Everybody knows about, now they're beginning to know about the neurology, stroke care.
That's become a model for the country.
Yeah, it's people have asked me. I had a friend of mine who had a stroke a few months back, and he went to Piedmont, and I said, "Oh, it's too bad you didn't go to Grady." And he looked at me like, "Grady?" And I said, "Unfortunately, you just don't know that. You don't know that the best care you can get for stroke care is in Grady." Those essential services that it provides, those services that it and only it, to use the Donald Trump phrase, burns, infectious diseases, sickle cell,
Diabetes is great too.
diabetes clinics, all those things that it does are often costly and can't be funded by just getting enough privately paid patients to come in there. The other thing, and this is tough, and it's hard to acknowledge this, but I think we have to, and that is that privately insured patients are probably never going to come. They're just not. They have options. And the perception of the hospital, rightly or wrongly, is still it's a poor people's hospital, and so therefore we should go to Northside or St. Joseph's or Emory, Crawford Law, whatever. And I think that makes it incumbent on the local governments to be able to say, all right, we recognize the value that Grady provides to the community, and we will support it financially in a way that keeps it not just open, but helps it thrive. We haven't gotten there yet. At some point, that old structure, the old part of that hospital is going to need some major renovation too.
Like one little story.
Yeah.
A good friend of ours is former president of Tennessee Blue Cross Blue Shield. Lives in just north of Atlanta, and he, we know him just very well, closely, and he had a incipient stroke just about 3 weeks ago. His arm became paralyzed. He called. I said, go immediately to Grady, which he did by ambulance. They laced the clot. He was asymptomatic the next day, and he's totally fine today. And he is a champion of Grady stroke center, as you can imagine. So it's slowly getting out.
Yeah, and the other thing that to keep in mind about public hospitals is that they fill this role in every big city in the country. The chronic diseases that Americans suffer from, particularly minorities suffer from at disproportionate rates compared to their majority patients, counterparts, are almost always the specialty care that is provided by the local hospitals, by the local public hospital. And they're the facilities in every major city that take care of those things. And I neglected to even mention this. This is a huge one. Behavioral health. If it weren't for Grady, you think the homeless problem we have in Atlanta now is bad. If it weren't for Grady, it would be even worse. And again, there's these essential services that need to be provided that should be fully funded through whatever the state can do to help facilitate Medicaid patients. But also, the counties have to step up and do better than what they're doing in providing this. Wait, hang on a second.
Andy had a
I guess
question.
a comment, maybe a lot tying up with what has been said here about Grady. I've had contact with Grady since 1958 and more so since 64.
Put it loud into the mic.
I said I have had contact with Grady since 1958 and more so for the 40 years that I came from 64 on and since then. There's something that has been missed whenever people talk about so-called charity hospital, which I never got that in the US. They're European. We don't call them charity.
Right.
We call them community or something like that. But what is lost a lot is the point that these gentlemen made and about how important it was for the training of the future generation of doctors. But what is missed by them as well as you and others in general is the contributions to the pioneering medicine and to research in the United States and many other places in the world. They were the places where the fundamentals of almost every specialty were made, where the first clinics were first. I was involved, say, with developing 6 clinics at Grady that were not there for the state of Georgia and more. But moreover, it's the contributions of research that at least until the 1980s and 90s at Grady, were made, of Emory were made at Grady.
Right.
You know, we were there, we contributed, we made research, and I had, and Bill knows, I put together 30 or so new things that were done, contributions at Grady. The first, you know, the importance of being earnest, firstest. We were the first in 30, whether it was in the city, in the state, in the nation, and in the country, at Grady.
Right.
And other hospitals. I trained at Boston City, that again made tremendous contributions for the following generation of researchers, not just teachers. So this must be understood, that these hospitals are very important for the teaching, the training, the care, without residents, without students, etc., fellows, where would we be?
Correct.
So,
Thank you for that.
but anytime I hear these things without comments about how those hospitals are important, were important for research particularly.
I wanted
I
to,
don't hear it.
thank you. I wanted to let you know there's a book by David Oshinsky, who's a great historian at New York University, that just came out in November about Bellevue. That's what it's called, Bellevue. And you should look it up if you're interested, because it deals a lot with that very discussion of how that hospital, going back to 1736, was at the forefront of American medicine in all sorts of things. Pediatrics in particular, but at every level, cancer, everything.
Can
And
I
it's-
mention another area that Grady's prominent in?
Sure,
Trauma.
yes, of course, yeah.
Orthopedics, I hired two people you mentioned today, Tom Price and Jim Robertson. And another one I hired at the same year, you may not have known, was Hamilton Holmes.
Oh, sure.
And orthopedics is rather big, and we have a new notoriety, is that we have the largest series reported of gunshot fractures of the tibia.
Wow.
With arterial injuries and stuff of that lady, like 400 in the last 6 years.
Wow.
So that's what goes on in Grady as well. And it is important in training of our residents, and it's well noted nationwide. We have 6 places, and this past year we had 825 applicants for those grades.
Wow.
We accepted 24 that we accepted the first 6 out of the 24 of 100 that we've interviewed.
Yeah.
So trauma is important to Grady too. It also is important, for instance, in fractured hips.
Sure.
We noted at Grady that if we operated on them within 24 hours rather than 5 or 6 days, we cut the mortality in half. We were able to do that better at Emory, where we cut the mortality from 10% to 3% in 200 consecutive cases.
Very good. Let me mention something about trauma. It's in the book. There's a whole chapter about trauma in the book. The interesting thing that's happening about trauma nationwide now is that some hospitals have begun to see it as a revenue source. In the old days, trauma was one of those things that only public hospitals provided because it was never going to make money for the hospital.
Now that gunshot makes.
Exactly. And there's the difference between what you like to hear, the difference between penetrating and blunt trauma and who does what. Well, what's interesting is happening in Florida right now, is that HCA hospitals and tenant hospitals and some of the for-profit hospitals have now decided to get back into the trauma business. And they're moving into level 2 trauma and other places surrounding the major trauma center provided by the teaching hospital nearby. So Jackson Memorial's Ryder Trauma Center now has to, I guess the right word is share patients, trauma patients, paying trauma patients with the hospitals surrounding it. which means that those gunshot wounds are coming into the Ryder Center at Jackson, and the others that are getting well paid for are going to the suburban hospitals that are owned by for-profit companies. So this is just the marketplace. This is how it works these days. And I think when public hospitals compete in this kind of marketplace, it helps you begin to understand that there are distinctive places and they need distinctive funding sources.
And of course, they trained those doctors.
They probably did train those doctors.
And I just wanted to mention another difficulty, I think, with Georgia that we don't think about
Mary
here.
Lynn, here.
Problem with Georgia that we may not think about very much, and that is that at Jackson, I did my residency at Jackson, and you could send a patient from another county to Jackson for help in dermatology. You can't do that in Georgia. There's too many little counties, and this is the Fulton DeKalb Hospital. You can't, from another county in Atlanta. Everybody knows if you're a patient that you better have an auntie in Atlanta, that you can put her address down that will enable you to go to Grady.
Yeah.
And it would break one of the little counties even to take care of one patient.
Right.
And so that is just not really addressed. It's saying, oh, we'll give it to the counties. Well, that's not gonna help us. So just tossing that out there, that it does help other states.
So much of how public hospitals are functioning is related to the arcane world of how we reimburse healthcare.
Yeah.
And that's a world that most people don't understand. Else we wouldn't be having this debate that we're having right now about replacing Obamacare with the ACA. I mean, there are a lot of people who don't know the difference between those two things, or that there is no difference between those two things. But because it's tough, it's really, and as a journalist, I can tell you, it's tough to explain.
Yeah.
Because it's really, really complicated. And we make it purposely so. Yes?
Someone mentioned pediatrics, but I should say that the first neonatal intensive care unit in the state was developed at Georgia, at Grady, when Dr. L. Brand came from Mississippi in 1975. And Grady was the first hospital to ventilate newborns, so many things, and that a special hospital intensive care unit for sick mothers was the only one in the state for many years, may still be, but so much was done in the area of maternal infant health, starting at Grady, including with the leadership from Grady, Emory, development of the regional, state regional maternal infant care centers. The infant mortality in Georgia has been reduced to a fraction of what it was in 1975.
At some point. And still wonderfully maintained by Bill Sexton and his crew down there now. Again, another one of these interesting things that happens when Medicaid was expanded to include pregnant mothers. Originally wasn't there. When it was expanded to include pregnant mothers, interestingly, the other hospitals around Atlanta and around the country began to create neonatal intensive care units for some of their patients. And what happened to the market impact of that was that some of those folks who had been going to Grady in the less complicated cases were now being able to get their neonatal intensive care at Northside or Gwinnett or Wellstar. And what left Grady with was the most intensive cases. And again, being reimbursed by Medicaid, it's not up to what they need. But yet, again, a noble decision to expand Medicaid to pregnant women so that they can get the health care they need. The marketplace responds in a way that the other hospitals say, okay, we can start getting some, we'll take those patients now, and leaves Grady holding the hardest cases. Joe?
Thank you. I enjoyed hearing a lot of your stories, and I've been at Grady since 2005 when Mr. Henry gave me a gift, and I'll never remember 2005, he purchased an ultrasound machine for us, and we were able to get this backlog of 6 months it took to get a mammogram. Back in January 2006, we cut it down to within 2 weeks with his support. So I do remember that story, and I really thank you for that. I also really thank Mike King for raising awareness about all of the challenges that we still have today. Though there is a very rich philanthropic support of Grady, we need the governmental support. And this played out in my area of expertise in breast cancer care. In October, there was a study published by the Avon Foundation that looked at the disparities of breast cancer mortality in the 50 most populous cities in the United States. And we had a nice story going in Atlanta way back when everybody was the same, a disparities gap, and then kind of the 2005 to 2009, that gap was narrowing. So I'm thinking that the last 5 years when that was going to be published, oh, I know that we're going to be so much better. The problem with the 2005 to 2009 is there was no disparities, but the survival of patients, both black and white, was below the national average. So I'm like thinking, we've made so many changes, especially at Grady, we're moving along, it's going to get better. Well, it turned out that from 2010 to 2014, it actually got worse. And now black women are dying at a much higher rate. The white women are doing much better now and much better than the national, but the disparities got worse. So what happened? It was ACA that didn't come to Georgia.
Right.
Now, Mr. Hopper has been really good at expanding Medicaid for our patients at Grady. We have a lot of patients who are on Medicaid and was able to tap into some of those resources. But when I question women who come in with their locally advanced breast cancer in the ED, why didn't you seek us out earlier? It's because the awareness has not been raised. So women still don't know in Georgia that there are programs. And so again, I really thank Mike King for going around and raising some of this awareness, but we all have to plug at it because it's not just going to be, we can't survive just on the philanthropic funds.
Okay. And the Medicaid story is fascinating to me, even without accepting the Medicaid expansion. In 2014, when the law kicked in and the exchanges opened and people started signing up, even without the Medicaid expansion, the people who currently qualified for Medicaid who didn't know they had it were able to figure that out by going through the exchange. And in that single act, Georgia added 100,000 people to the Medicaid growth. 100,000 in the space of about 3 or 4 months. And it's interesting to me that A, they didn't know they qualified in the first place, and B, when they did qualify, they decided they were going to utilize that care. And now you're going to hear this in the next few weeks, that, well, see, the Medicaid expenses are going to go through the roof because these people just don't know how to take care of themselves. They're still showing up in our emergency rooms and every place else. And you'll hear a study about an Oregon study about ER use among the newly insured Medicaid patients. And the answer is, for the first time in their lives, and in some cases, often the first time in 4 or 5 years, patients are able to get some health care. So guess what? They accessed it. And it's the same thing that takes place when you look at it from age 65 to age 68. There are a lot of people who put off health care at age 63, 64 until they are Medicare eligible. And so the high expenses of ages 65 through 67 are directly related to the fact that people didn't get health care before because they had no access to it. So it shouldn't surprise any of us that Medicaid patients who finally qualify for it are now getting care.
We've got Mario.
I have a comment and a question.
Sure.
I've spent 22 years at Grady and heard almost anything, and the comment is sort of notoriety in this heavy. The emergency room, we heard about a lot of people coming gunshot wounds, and I remember one time we had a patient that had been shot, and policeman asked who shot you. He said, a friend.
A good friend, yeah.
The other thing is the Calvin and
Fulton.
Fulton, you mentioned that reduced their contribution, but what about the other counties? They still send patients to Grady because we cannot refuse patients.
Right, there is no funding from other counties. It is a county authority hospital for those two counties, not for the other counties. When it was in trouble in 2008, I looked at some data, and in the state requires Grady to fill out a form every year called the hospital annual questionnaire. And it states where those patients, what counties those patients come from. And of course, the vast majority of them are Fulton and DeKalb. It's not as many from outside of those two counties as you would think. I used to think the same thing, that there would be a lot of influx from the other two, from particularly the two other big counties, Cobb and Gwinnett. But it's not. Not that there isn't some, but there are, but it's not as many. The one exception to that is Clayton. Clayton has a large percentage of its poor population that comes to Grady. And what's important about this is that Clayton's public hospital, Southern Regional, is teetering now too. And I think, and it always has, it's always sort of operating on the edge. If there's a big picture notion to maybe what could be done in the next 15 or 20 years, I would think there might be a reorganization of how public hospitals are structured in the metro area that would put Grady at the head of a group of hospitals, including maybe Southern Regional, DeKalb, and a few other hospitals that are sort of in financial constraints right now, so that we could spread this load around. Stroger Hospital in Chicago has a community hospital connected to it, so it's not just the big county hospital, but there's a community hospital there too. What's it called, Providence?
Yeah, Providence Hospital. I worked there.
Did you?
I worked at Providence Hospital.
Providence Hospital is a community hospital for the county system in Cook County. So there's a big picture answer maybe to how we structure and pay for health care in Georgia. And frankly, we need to have that discussion at some point, because rural hospitals are in deep, deep trouble. And they're in a totally different category. They have some of the same inherent problems with their patient pay mix being terrible as Grady has, but it's a totally different situation with them. We frankly overbuilt those. There were too many of them. One of the reasons we overbuilt them was there's an act passed in the 1940s called the Hill-Burton Act. It was a federal law that helped rebuild hospitals after the war and build rural community hospitals around the country. And the first 5 hospitals built with Hill-Burton money in the late 40s were in Georgia. And they were in tiny little communities. And I think all but one of them are gone now. That's a totally different issue, but it's related in the sense that we ought to be thinking in a different way of structuring how we do public hospitals.
Okay, Mort, you had a question?
Any comments about Tom Price and Grady?
His time Grady was only a few years, right?
Right.
Yeah, I mean, I think 2 or 3. And my sense of it was
We're talking back
yes,
for about 2 years later.
yes, and I'm not sure how much clinical care he provided.
Very little.
Very little, okay. Now, let me just say about Tom Price. At least he's put some things out there, which is more than most Republicans have done. Now, they're all things we've heard before and have demonstrably failed in a lot of ways, but at least he's put some things out there. So I'm not, this is, of the appointees that the new president has put up before us, here's one who is at least qualified. I mean, he does know what he's talking about. I think what happens over the next few months is going to be the result of whatever consensus the Republican members of Congress can build among themselves, and then walk up to Pennsylvania Avenue and trick him into believing it's his idea and you know, because with him, it sounds like whoever is nicest to him most recently is the one. And so, and I think Tom Price and Paul Ryan are smart enough to figure out how to do that. But he could go, you know, he could go off script the next day and all of a sudden, I mean, he went off script a couple of weeks ago and there was sphincter tightening going on all over them. When he said he's going to get insurance for everybody and it's going to be low cost deductibles. Well, you can't do that. It just, there's a way to do that. It's called the national insurance, but that's not what they're going to do.
Can I say something about Tom?
Yes.
When I interviewed him for a residency, he was obviously qualified. Family, father and grandfather physicians. He was from Michigan.
Right.
And then he came here as an intern, thinking about general surgery. And then he changed his mind, and I hired him into orthopedics. I said, what do you want to do? You going to go back to Michigan after this? He said, I don't know. I might be local, but I'm still interested in politics.
Yeah.
But he finished his residency and went and practiced in northern Fulton County. And then something happens that tells you something about his character. One resident who had been a resident under him for the next 3 years joined him in practice. They know more about your character than I knew as chairman.
Sure.
And so he went to practice, and practice was very successful. And he left it when he needed to work somewhere to get health insurance when he was in
the legislature,
chief of the Senate here in Georgia.
Right.
And he was part-time faculty at Grady, and he did a creditable job at that.
Right. He was reviewing a lot of patient charting for Medicare and Medicaid purposes. So he knows those two programs.
The interesting thing is we had a Saturday morning conference, which wasn't common. And it was didactic. We had guest speakers and all that. Not every other, when he wasn't on call the night before, he would come in hungover. And I thought he'd been going to the cheetah like I read ahead of him had been doing. But this happened until he met an resident and married her, and then he came in, you know, kind of bright on.
Right out of bushy.
But what he had been doing, he hadn't been going to the cheetah. He and the chief resident in neurosurgery, who's now the chairman of neurosurgery, they would go and talk politics at a bar on Friday.
Yeah.
And he'd come in, not drunk over and go to coming in sober.
No, I don't know him very well, but I do know a lot of people who have worked with him, and he is a politician first.
And then also, if you're in the situation I was, if you were screwing up, I would hear it. In practice, I never heard anything bad, and all of the patients I got from him were handled first class.
Yeah, and his practice eventually was absorbed by resurgence, I think, which is huge.
Yeah.
Yeah. Great.
In terms of rural hospitals, there are a lot of rural areas in Georgia, and they're clearly rural poor. I assume they're not special charity hospitals, and that the public hospitals then take those poor patients. Is part of the problem they're having because there hasn't been Medicaid expansion, and so
definitely.
Therefore they're having financial issues. And
rural hospitals are. The question is whether Medicaid expansion has impacted rural hospitals, and there's no doubt that it has, because we have a lot of poor counties in Georgia. We also have too many counties in Georgia, but and every one of them wants a hospital. Yes, the Medicaid expansion would help them a lot. It would not solve their problems. I think, and there's another piece of me that wants to do the next book on this issue. I think the answer is something that something that doesn't exist today. It's some kind of a regional acute center that staffs ambulance services and emergency services and quickly transports people to larger regional public hospitals around the other part of the state. And I base that on the fact that, you know, in sparsely populated parts of the West, this isn't as big a deal as it is in Georgia, where we've got hospitals within 15 miles of each other. And both of them, you know, when I was writing about in that disparities story I wrote in 1992, I was impressed about how many hospitals in Georgia had another hospital within 20 miles. And there was one in Sparta. I focused on Sparta, Georgia, Hancock County, that had a 50-bed hospital. On any given night, there was maybe 7 patients in it, okay? And those are primarily Medicare patients who really needed nursing home care, and were just there because the local docs, there were 2 local docs who admitted patients to that hospital. Down about 5 miles away in Sparta was a federally qualified community health center that took care of a lot of poor folks, When those folks got sick and needed hospital care, they didn't go to Hancock County Hospital. They went to Augusta, which was 45 miles away, or 50 miles away. Now, what was it? It was, to some degree, it was probably a history of racism, because a lot of the patients at the federally qualified health center were black. The hospital was overwhelmingly white. The 7 or 8 patients who were in there were all white. The 2 doctors who served the community were both white. And it was crappy care that they were getting. They were much better off going to Augusta to get care. So there has to be some kind of a birthing emergency helicopter service or something that will be the answer to rural hospitals. It can't be propping up every 50-bed hospital or switching them to swing beds so that 25 of them are nursing home beds.
Mike, that exists already in this program.
Right, and that's correct. Good point, Dr. Casserole. Yeah.
There are 50 hospitals in that.
In the stroke network, yeah. And they helicopter them, right?
Yeah, well.
Sometimes. Yeah.
We can do one more question, Stuart.
I'm Stuart Roberts. I'd like to comment here, perhaps in the summary form.
Sure.
Our country is ranked 37th internationally in healthcare, and our average longevity of each citizen is ranked 47th. So I think that speaks to the disparity of our healthcare and our need for public hospitals. We're the only technically advanced democracy that does not have universal health care for all of our citizens. France is generally rated number one in health care internationally. They spend 12% of their gross domestic product on health care. We spend 17.1% of our gross domestic product on health care. And we have perhaps 25 million uninsured and millions more underinsured. And we have 700,000 medical bankruptcies a year. And this leaves wide open room for improvement. I think a good idea would be to go to Congress and say, we want the #1 healthcare program in the world. And we want it at 12% of our gross domestic product. Now, you get together with the pharmaceutical firms, the medical equipment manufacturers, and the hospitals, the insurance carriers, the doctors, and the lawyers. And you work it all out so that we have universal health care, #1 ranked in the world, at 12% of our gross domestic product. Period.
Yeah. Well, thank you. We have a bargainer in the White House now, and maybe he could drive that bargain. It was interesting to me in 2008 and 2009 when we started the debate the last time, when the decision was made. It was a critical decision made to not allow for a public option in this exchange. And that was in some ways a fatal decision for Obamacare because it relied so heavily on commercial insurance to be able to carry the water here. And I thought if the election had turned in a different direction in November, all the damn polls said it would. I thought that the next step would be to sort of help make this work better was to enact a public option over the next few years that allowed people the option of being able to buy into Medicare from age 55 to 65 or something like that, so we could relieve some of the tension on the older population costing so much and the younger population paying for it. Of course, that didn't happen. But if it had, I think we would have been on the track towards getting something that's close to a universal health insurance plan. Now, where are we going to go from here? I have no clue. And I'll leave you with this. We've been debating this for 100 years. Every other major industrial nation in the world settled this debate decades ago, but not us. Why is it that we haven't? It's because I don't think we know how to treat poor people in our country. We talk about it. We think we can. We think we can do it with, 1,000 points of light and church groups and things like that. And they do wonderful work. But we have to make a commitment at some point that says Americans have a right to
care of the provider, number one, not the patient, not the citizen, the provider.
Well, let's give Mike and a round of.
By the way, available for purchase if you're interested.
Available for purchase. I also wanted to mention another available for purchase. 2 weeks hence, it'll be up on Amazon for anyone who wants it. This is B. Namia's book,